Hello, and welcome to From the EBPL Archives, Encore presentations from the East Brunswick Public Library. I am your host, Melissa Hosick. This event was presented as part of our Just for the Health of It initiative. Just for the Health of It is a proprietary health literacy program developed by the East Brunswick Public Library to promote health literacy in Middlesex County. To learn more, visit justforthehealthofit.org. Now, enjoy the program.
Welcome, and thank you for joining us this afternoon for today's Lunch and Learn with a doctor on gastroesophageal reflux disease. My name is Kathy Chern, and I am a consumer health librarian at East Brunswick Public Library. Today's program is brought to you by St. Peter's University Hospital and the library's Just for the Health of It initiative to promote community health and wellness. Today's speaker is Dr. Sugirdhana Velpari, gastroenterologist and director of the Gastrointestinal Motility and GERD Therapy Lab at St. Peter's University Hospital and Assistant Program Director of St. Peter's Gastroenterology and Hepatology Fellowship Program. Please be aware that this talk is being recorded. Please keep your microphones muted and your webcams off. The recording will be available at ebpl.org/YouTube. If you have any questions, please type them into the chat box. The doctor will answer questions at the end of the talk. The doctor will not be able to offer personal medical advice to attendees during this program. And without further ado, I shall turn things over to Dr. Velpari.
Wonderful. Good afternoon, everyone. Catherine, thank you for that introduction. I'm very happy that all of you are able to join me today. I know some of you are actually my own patients at East Brunswick, and so hopefully you find this lecture beneficial. So let's get started here. So as Catherine said, the talk today is on GERD, which is short for gastroesophageal reflux disease. All right, so what are we going to cover today? First, we're going to cover what is reflux disease, what entails that disease entity, the risk factors for it, how do we diagnose acid reflux, the complications of it, and finally, the treatment modalities for reflux disease. So, people interchange the names for GERD. Some patients or providers will say reflux disease, others will say acid reflux, heartburn, pyrosis, regurgitation. So the two typical symptoms for reflux disease is heartburn and regurgitation. And heartburn essentially is a painful burning sensation in the middle of the chest. It can start in the upper part of your stomach and radiate all the way up to your throat. It typically strikes after meals and it can last several hours or even throughout the whole day. This discomfort can worsen when someone is bending over, lying down, exercising, or exerting themselves. The second common typical symptom of reflux disease is regurgitation. And this is where there's a perception of flow of reflux stomach contents up into the mouth. And sometimes it can actually even be undigested food. But typically, patients will complain of the sour taste in their mouth, and they can sometimes even feel that radiating up from their stomach up into their throat. And so these are the two typical symptoms of reflux disease. However, there is quite a few atypical symptoms of reflux disease as well, and this includes a chronic cough. The two other common reasons for chronic cough include postnasal drip and asthma, and so sometimes it's multifactorial, where it's all three causes, and so quite often we work with the pulmonologists as well as our ear, nose, and throat doctors and colleagues to really get to the bottom of why someone has a chronic cough. And sometimes with reflux disease, that's the only symptom that you have. You might not have the typical symptoms of heartburn and regurgitation that I spoke about. Other symptoms that are atypical, asthma. So asthma can be exacerbated by reflux and vice versa. Asthma can exacerbate reflux, but reflux can exacerbate asthma. And so quite often those two are a combined entity. You can get a change in your voice or hoarseness, chronic throat clearing. Some patients complain of chest pain, usually after eating, although when someone complains of chest pain, our first goal is to make sure it's not the heart causing that. And if it's not a heart issue, then it's a non-cardiac chest pain. And one of the entities that can cause it is acid reflux. There can be trouble swallowing, especially if there's complications of reflux, which we'll get into. Water brash, which is this feeling of excess saliva accumulation in the back of the throat or inside your mouth. Globus sensation, which is where you always feel like something's kind of stuck in your throat, but there's really nothing stuck there. It's most likely due to irritation of that throat area because of reflux, giving you that sensation that there's something there. Some patients, they go see their dentist and they have multiple dental erosions, and sometimes the dentist will ask them if they have acid reflux. And this can happen because of the damage from the acid itself, and halitosis, which is bad breath. So why does GERD happen? Well, as you can see here, once you swallow food or drink any liquids, it makes its way down your esophagus and into the stomach. With gravity's help, there's a muscular valve called the lower esophageal sphincter, which you have labeled right here. And that sphincter keeps stomach acid in the stomach from refluxing back into your esophagus. And in patients who have reflux, quite often, this sphincter does not work well, whether it's because it's not strong enough or perhaps because of some sort of anatomic defect. The diaphragm muscle, which helps strengthen that sphincter, is not working properly. So quite often there's an abnormality with the sphincter. Either it's displaced or it's weak, and quite often that's the reason behind, or one of the reasons why you can develop acid reflux. This is just another description of how our body functions when we eat. So essentially, once you eat your food, there's acid that is created, and that acid mixes with your food. And so if that sphincter, which is right here between your esophagus and stomach, if there's an abnormality with that sphincter, then it's easy for stomach contents to reflux back up into the esophagus, causing the symptoms of acid reflux. So who is at risk for reflux disease? What are the risk factors? Well, anyone can really develop acid reflux, but there's certain lifestyle factors that affect how well the sphincter works, as well as the amount of acid being produced by the stomach. One of the, if not the biggest risk factor for acid reflux is being overweight or obese, the presence of a hiatal hernia, which I'll describe a little bit more into detail, eating large meals or certain types of foods or drinks. So we typically see that acidic foods, citrus types foods, spicy foods, fatty or greasy foods, chocolate, mint, caffeinated beverages, including coffee, alcohol, smoking. These are typical foods and drinks that we see that trigger reflux symptoms. Wearing tight-fitted clothes, that's more of a pressure issue. So if you have something pressing on your stomach and it's quite tight, then it's going to also cause reflux into your esophagus. Certain medications, and actually quite a few medications, can trigger acid reflux, including antidepressants. If you're on painkillers such as Vicodin or morphine or Dilaudid, Compazine, some anti-nausea medicines, some asthma medications, even some blood pressure medications. So there's quite a few medications that can trigger acid reflux. And the thought is that those medicines work on that sphincter that I was speaking about and can loosen or decrease the strength of that sphincter. But quite often, many of these medications are treating other medical problems are necessary. And so we can't really stop those, although we try to keep patients on the lowest effective doses. If there is a history of scleroderma or systemic sclerosis, this can affect the esophagus, where the muscles of the esophagus don't work well, and that sphincter becomes really weak. And these patients are at very high risk for reflux, and quite often they're on very high doses of medicines to treat it. And finally, excessive alcohol use as well as tobacco use. These can be other risk factors for acid reflux. So what is a hiatal hernia? Well, first of all, a hernia in general it's any time there's an internal body part that pushes into an area where it doesn't belong, and that's what's called a hernia. In this case, it's a hiatal hernia is where there's an opening in the diaphragm. So this is your diaphragm muscle right here, and that muscle separates your chest from your abdomen. And so typically your stomach is below that diaphragm muscle. What happens with the hiatal hernia is part of that stomach finds a way up into your chest cavity. And so when that happens, that sphincter that I was speaking about, which is usually right at that diaphragm muscle, is now displaced upwards towards the chest cavity. And so both now that sphincter doesn't work very well because it's not getting that added strength from the diaphragm muscle, but now part of your stomach is somewhere where it shouldn't be. And so there's different types of hiatal hernias. One is a sliding hernia, one's a paraesophageal hernia. The bottom line is having one of these can predispose you to acid reflux. So again, what is the role of hiatal hernia and reflux? So again, as I was saying, it can weaken that sphincter, and quite often you can have a hernia without any reflux symptoms, but if someone does have reflux symptoms, many of them do have this hernia, and we do assess for this when performing an endoscopy or some sort of swallow study with a radiologist. So obesity, as I was mentioning before, is one of the risk factors for acid reflux. And this is essentially where there's excess body fat accumulation, which has bad effects on your health, including the development of acid reflux. And the numbers are quite alarming. The percentage of patients in America who are adults that are overweight is 70%. And out of that, 70%, well, 38% of them are obese. And so this is an issue. It's an issue that not only affects us from a reflux standpoint, but obesity, being overweight, has a lot of other ramifications and is a risk factor for many other medical problems, one of them being acid reflux. So just to go over the classification of how we label a person as being overweight or obese. So normal weight, and this is a combination of both your height and weight taken together, and this is how this number is calculated. A normal weight is usually with a body mass index between 18.5 to 25. And again, we take your height and weight and come up with this number. And there's calculators online that can give you this number if you plug in your height and weight. Overweight is once your body mass index is greater than 25, and then you're classified as obese once your body mass index is greater than 30. And within obesity, there's three different classes. And obviously, the higher your class of obesity, the higher your risk for complications, including acid reflux. But that being said, I've seen many people who are normal weight or even underweight that have acid reflux. So how do we diagnose acid reflux? So in most patients who come to my clinic or a gastroenterology clinic, we go through a thorough history and really try to figure out what their real symptoms are that are bothering them. And quite often, just from the symptoms themselves, we can come up with a suspicion for acid reflux and treat them appropriately. However, the gold standard is an endoscopy with reflux testing. And I'll go through the two types of acid reflux testing that can give us really objective evidence that you have acid reflux. Although there's typical symptoms of acid reflux, these symptoms are not always due to acid reflux. And so if someone does not respond to the regular treatment for acid reflux, then quite often we need to really try to get objective evidence to figure out, is this actually truly acid reflux, or is there some other reasons such as a motility disorder or something maybe in the stomach that's going on that's causing the symptoms. And so quite often we will need to proceed into actually really doing objective testing with an endoscopy and pH testing. And I'll go over the two types that we typically use. There's also the esophageal manometry, and that's a test to really look at how the muscles of your esophagus work, because quite often if the muscles of your esophagus don't work well and it's not pushing food and liquid down into your stomach, then that can also cause symptoms that are like acid reflux, but really it's because the esophagus isn't working too well. So the two types of reflux testing, I'm not going to get into too much detail here, but the two types is there is a wireless capsule-shaped device test, which is called the Bravo test for acid reflux. And what happens here is during your endoscopy, we attach this capsule that you see right here to your esophagus. And this stays there, and you basically have a monitor on you for about 2 days. And you can see that right here with a receiver. And this will document how much acid is being refluxed up into your esophagus over a 2-day period. And then this receiver is brought back to us, and then we review the results and determine if you really have true acid reflux. There's certain parameters that we use to diagnose it. The second method is a transnasal place catheter, and obviously, as you can see, this is not the most comfortable test, and so quite often we use the wireless because you can't see it, it's inside your esophagus, and this falls off after a few days. But the second method is a transnasal place catheter, where essentially you go home with this catheter down your nose for about 24 hours, and this will assess how much reflux is occurring. It gives us some additional information that the Bravo capsule might not. So sometimes we do resort to using this as well, but quite often we'll start with the Bravo capsule, and if needed, we will also perform this second test as well. So this is just to show you the two types of common ways that we assess for acid reflux. So how common is this problem? Well, in the Western world, the prevalence is about 20%. And so out of every 5 people out there, at least one person is affected by acid reflux. And why is it important? Well, it's important to know if you have acid reflux because this can cause other complications, and we'll go through those complications. So the complications of reflux disease, esophagitis, esophageal ulcers, strictures, Barrett's esophagus, Esophageal cancer, again, not very common, but it is a risk factor. Reflux is a risk factor for esophageal cancer, lung and throat problems. And we'll go through each one of these in a little bit more detail. Finally, many patients have such severe symptoms that their day-to-day quality of life is decreased as well. And I think this is a complication in itself. These are medical complications, but this is really a complication where quite often the reflux is so bad that patients' day-to-day life is just, their quality of life is terrible. So the first complication, esophagitis, esophageal ulcers. This is essentially where acid reflux is causing inflammation and true damage to your esophagus. And this can happen up to 40% of patients who have low acid reflux. And you can see here, this is normal mucosa, okay? But you see these little irritation spots, and this is esophagitis, this is esophageal ulcer, and this is injury that's caused by the excess exposure of your esophagus to acid. And sometimes this is so severe that it can cause bleeding, but it can also cause strictures. And so when your esophagus starts to narrow, quite often people will start to complain of trouble swallowing, food getting stuck in their chest. And this could be because that inflammation became so severe, it's causing fibrosis and scarring and now a narrowing, which will affect a person's ability to eat. Barrett's esophagus. Some of you might have heard of this entity, and this is where the normal cells of your esophagus, it typically happens in the lower part of your esophagus, are replaced by a different type of cell. And this is usually caused by reflux disease. And the reason why it's important for gastroenterologists as well as a patient to know if they have this is this is a precursor to esophageal cancer. And there's certain risk factors for developing Barrett's esophagus. So what are the risk factors for developing Barrett's esophagus? It's essentially in patients who've had chronic long-term reflux for many, many, many years on a frequent basis, more than on a weekly basis, and are much older, usually age 50 or older. That being said, I've seen it in people even younger who've had reflux since they were in their 20s. The male sex, white or Caucasian race, elevated body mass index, so if you're overweight or obese, a history of smoking or current smoking, and a previous family history of Barrett's or esophageal cancer, especially in a first-degree relative. All of these are risk factors for developing Barrett's esophagus. And so when a patient comes and sees us in clinic, we certainly keep this in mind and figure out if there are these risk factors and determine if a patient is a candidate for screening for Barrett's. Again, not everyone with acid reflux requires screening, but if you have a few of these risk factors, then we certainly have a very low threshold to assess for Barrett's esophagus. So how do we assess for esophagitis, ulcers, strictures, narrowing, Barrett's esophagus? It's with an upper endoscopy. And this is where, under sedation, a camera is placed through the mouth, through the esophagus, all the way into the stomach. And so we'll take a look at the whole esophagus, look for any abnormalities from acid reflux. At the same time, we can also assess the stomach, make sure there's no ulcers or inflammation there, and even part of the small intestine. And so it is great in terms of essentially looking at the organs of the upper abdomen when it comes to acid reflux. Now, to diagnose Barrett's, quite often, it's not just looking at the esophagus, but taking samples, which do not hurt. It's also under sedation, and those samples are sent to a pathologist, and that's how we make the definitive diagnosis of Barrett's. So what are the symptoms of Barrett's? Well, there is no symptoms of Barrett's. And so that's why it's important for us to really decide if there's risk factors for Barrett's, which would then prompt an upper endoscopy. The symptoms of Barrett's is similar to reflux, but reflux causes Barrett's. And as I said before, all Barrett's is a changing the lining of the esophagus. So it doesn't have any symptoms that are different than regular acid reflux. And for some patients, which is can be scary, is you might not have any symptoms at all because over time your esophagus has become desensitized, and you might have had severe reflux symptoms years ago, but now over time you haven't really had much reflux symptoms because your esophagus has desensitized. So, it can be a tough diagnosis to make, and so we always try to have a very low threshold to evaluate this if we deem necessary. So, how is Barrett's esophagus treated? Essentially, it's with antacids, and it's a certain type of antacid. It's our proton pump inhibitors. And those are your omeprazole, which is Prilosec. There's esomeprazole, which is Nexium, pantoprazole, which is Protonix, dexlansoprazole, which is Dexilant. I know they have two names for all of these drugs. And so those proton pump inhibitors are the treatment to prevent the progression of Barrett's to esophageal cancer, which is what we're trying to prevent. Now, if we do monitor patients who have Barrett's esophagus every few years, and we see that it's advancing to the next level, then there's certain ablative therapies where we can try to burn the Barrett's and get rid of it. But just regular Barrett's, there's no need for that. It's only if it starts to worsen in terms of the type of Barrett's it is. Now, what is the true risk of getting esophageal cancer if you have Barrett's? Well, there's a 30 to 50-fold increased risk, but the chances of getting esophageal cancer is still quite low. It's about 0.5% of patients with Barrett's esophagus develop esophageal cancer per year. And so as long as we're treating it appropriately with the acid reflux medicines, and as long as we're keeping an eye on it every few years, then we are able to prevent the development of esophageal cancer in the majority of our patients. And this is just to really demonstrate how esophageal cancer is on the rise. There are two types of esophageal cancers. There is esophageal adenocarcinoma, which affects the lower part of the esophagus, and that's what's associated with acid reflux. There's a second type called squamous cell carcinoma, and that typically affects the upper portion of your esophagus, and that's more due to tobacco use, although tobacco use can also trigger acid reflux. And for one reason or the other, just looking at these two charts here, the blue line is for squamous cell carcinoma, and the green line is for adenocarcinoma, which is the one that's associated with acid reflux. And as you can see throughout the decades, that incidence of adenocarcinoma has gone up. Mainly in males. In females, it's the risk of squamous cell and adenocarcinoma has leveled out. But essentially males, it has gone up. And it's unclear exactly why. Perhaps more patients are getting acid reflux from being obese and overweight and all those risk factors we're talking about. And so we think that's probably why there is that increased incidence of esophageal cancer that's attributed to acid reflux. And so that's even more important of why it's important to be evaluated if you have frequent symptoms of acid reflux, to be tested and ruled out for Barrett's. Again, this is just another chart to demonstrate how, although the rates of esophageal cancer are still low, the incidence where the number of patients getting esophageal cancer is increasing compared to the other cancers. But again, still the rates of esophageal cancer are much lower. It just the incidence of it seems to be rising. So lung and throat problems, that's one of the other complications from acid reflux. Not everyone, acid reflux gets throat issues, but patients where it does reach the throat, it can cause inflammation of the vocal cords, and this is where you can get a sore throat, a change in your voice, chronic throat clearing. It can also be inhaled into your lungs. The reflux can cause occasionally aspiration pneumonia. It can worsen asthma symptoms, and sometimes, very rare, it can also cause fibrosis and chronic damage of the lungs. I've seen a few of these, but still very, very rare. And it's typically people who've had uncontrolled reflux for many, many, many years who develop this. Okay, so reflux symptoms or reflux therapy. The initial therapy for all patients with acid reflux is really lifestyle and dietary modifications. Through our data and our literature, the three most helpful treatments lifestyle-wise to reduce acid reflux symptoms is weight loss, placing the head of the bed about 4 to 6 inches, elevating the head of your bed about 4 to 6 inches. Sometimes I recommend patients to buy a wedge pillow from Amazon or any store, or using a few pillows, but it seems like the wedge pillow is a little bit more comfortable. And third, avoiding late night meals. So I recommend patients to, if they're sleeping at 10, not to really eat anything after 7. So waiting at least 3 hours. All that food is still in your stomach. And so if you go right to bed, it's going to have a very easy time refluxing back into your esophagus. And especially fatty meals tend to be the higher trigger. But either way, avoiding late night meals. So those are the three most helpful lifestyle changes. Now, selective elimination of dietary triggers. This is a tricky one. As I had mentioned before, citrus, acidic foods, spicy foods, fatty, greasy foods, alcohol, caffeine, chocolates, mint. These all are common triggers, but it's not the same for everybody. So it's individualized patient to patient. And so quite often what I typically do in the beginning is start a bland diet by removing all of these, but then also having the patient really have a food diary, keep a food diary, and see if there's certain foods or drinks that trigger their symptoms. I've seen patients who they take one bite of spaghetti with tomato sauce and they have the worst reflux. And then I have another patient who can have spaghetti 3 times a day and have no symptoms of reflux, but then a piece of chocolate causes them terrible acid reflux. And so, although these are all common triggers, quite often there are certain triggers for each patient, and it's important to individualize that so we're not really limiting their diet too much as a general statement. Wearing loose-fitted clothes, and then avoiding tobacco and excessive alcohol. So those are the main lifestyle and dietary modifications. If those don't help, then quite often we need to start a medicine. There are over-the-counter Tums and calcium carbonate, which Malox, and those are okay if you have occasional reflux, maybe once or twice a month. But if you're having more frequently, we'll try the weaker antacids such as Pepcid. Zantac is off the market now, so there's Pepcid and cimetidine. But if you're having symptoms on a weekly basis, then most likely you're going to need the stronger acid antacid medicines, which are your proton pump inhibitors. A couple examples are omeprazole or pantoprazole. Some of these you can get over the counter. Others you need a prescription. And so for the majority of our patients, lifestyle and dietary modifications plus or minus antacid medicines will do the trick. However, there are a subset of patients where, unfortunately, once they are diagnosed with acid reflux, again, we have to make sure there's no other causes that are causing their symptoms that are refractory to these treatments. they might need additional interventions. And these are more invasive interventions, including surgical and endoscopic interventions. And just to touch upon some of the options out there, one is a fundoplication. What is that? If you have a hiatal hernia, then sometimes that needs to be fixed, right? So you got to bring the stomach down to where it's supposed to be, and then you take part of the stomach and wrap it around the esophagus to hopefully prevent a recurrence of the hernia, plus prevent reflux of stomach contents up into your esophagus. And so if you have a very large hiatal hernia, sometimes this is the recommendation. There's also a relatively newer procedure called the Lynx procedure. And this is where if you don't have a very large hernia, you can bring that stomach down and then place this magnet around that sphincter between the esophagus and stomach. And that sphincter helps prevent acid reflux. And I've had a few of my patients get this, and they've done quite well. There's also a couple endoscopic therapies that we can provide. One is a stretta therapy, which is basically ablation of that sphincter, causing a narrowing. It's almost like a functional narrowing of your esophagus, so that that sphincter is a little bit tighter and works a little bit better. And the transoral incisionless fundoplication. This is a newer entity, and this is where instead of going through the surgical route for hiatal hernia repair, you can go through an endoscopic route where we actually use the endoscopy to create the fundoplication. And so obviously, there's a lot more information about these different options, depending on where you go, depending on where you live. You know, these options, some of them are available and others might not be. So it also depends on that. But the bottom line is patients who are objectively diagnosed with acid reflux, who are refractory to lifestyle and medical therapy, there are surgical and endoscopic therapies to help out. So in summary, just to wrap up here, again, heartburn, regurgitation, those are your typical symptoms of reflux, but there's quite a few atypical symptoms that can cause that can be due to acid reflux. There is objective methods to diagnose acid reflux other than just going off of a patient's symptoms. We always start with lifestyle modification, and if needed, medical therapy, including antacid therapy for acid reflux. However, if those are suboptimal or refractory, then there's certainly there's surgical or endoscopic options available. Again, treatment isn't just to improve symptoms, but it's also to prevent the complications that we spoke about. And one of the complications is Barrett's esophagus, which is a precursor to esophageal cancer. And certainly it's important for us to evaluate that in certain patients so that we can monitor it and treat it appropriately. So that is the end of my talk today. This is just some humor that you can see on my slide. So, right.
Okay, thank you. So we'll start the Q&A session now. So if you have any questions, please type them into the chat box. And as a reminder, the doctor is unable to offer personal medical advice to attendees during this program. So, so we have a previously submitted question. Will drinking aloe juice and apple cider juice help prevent acid reflux?
Yeah, that's a great question. I have a few patients that have come in and have also mentioned that these taking these products have helped their symptoms. You know, from my medical literature, there is no great evidence to suggest that these are helpful in treating acid reflux. Part of it isn't so much that it doesn't help, we just don't have many studies that are done on that. So that being said, If you have occasional symptoms and it works, then great. However, really, someone who has frequent acid reflux symptoms, we don't recommend that as a mode of therapy, and whether it's really effective or even safe to be taken frequently or every day is unknown. So we certainly go with evidence-based literature, and at this time, there isn't much to really recommend that from a medical perspective.
Okay. And then what are foods that will help prevent acid reflux?
There isn't any food that necessarily prevents acid reflux. It's more so avoiding foods that trigger acid reflux. And we certainly went over those common food triggers. That being said, I've had people who come in and they say a certain vegetable triggers their symptoms, and so sometimes it might be an uncommon food trigger, which occasionally is a healthy food, such as onions or broccoli. So, overall, there isn't any foods that prevents acid reflux. It's more so avoiding food triggers is where we are. Again, if we do tend to see greasier foods and spicier foods to trigger symptoms, and so and they tend to be more of the unhealthy types of foods. So we've noticed some more high fiber diets, eating a lot of fruits, vegetables, limiting the amount of grease in your food does help limit reflux symptoms.
We have a little comment that they like the comic. And then another question, is PPI treatment dangerous long term?
Yeah, great question. So with proton pump inhibitors, just like any medicine out there, they can certainly have side effects. And there is more and more literature coming out stating that these medicines can be associated with quite a few adverse effects out there. However, none of them have actually been proven to be the cause of those adverse effects, just more of an association. Could that be because so many people are on these medicines, a lot of them are older, and they're at risk for osteoporosis and renal disease and dementia, possibly. Overall, these medicines are relatively safe, but what we do in our clinic is to determine, first of all, do you even need the medicine, right? If you don't need the medicine, then obviously the risks outweigh the benefits because you're taking a medicine that potentially could have side effects and it's not doing anything for you. So we try to stop these medicines in people who don't need it. In patients who really need it, we wean them down to the lowest effective dose. And so omeprazole, there's different doses. There's 20, there's 40, there's up to 40 twice a day. And so if your symptoms are controlled on 20 daily, then I'm not going to keep you on the 40, right? I'm going to bring you down to the 20, and hopefully that'll decrease your risk for these adverse effects. But if I take you off of this antacid and your symptoms are terrible, then at some point you have to take in your quality of life, the risks of uncontrolled reflux, and weigh the risks and benefits. And patients who really need these medicines, the benefits do outweigh the risks.
Okay, so that's it for questions. All right, so thank you, Dr. Velpari, for taking the time to present on this topic and to answer our questions. The next topic in this series is Basics of Inflammatory Bowel Disease on Friday, November 6th at 12 p.m. noon. So thank you, everyone, for joining us for today's talk. And thank you, and stay safe.
Wonderful. Thank you. Thank you for taking the time out of your day. So hopefully everyone learned a few tidbits about reflux disease. So, wonderful. Thank you.
All right, thank you.
Thank you for joining us for this week's Encore presentation. To join us for live programs or to learn more about the East Brunswick Public Library, visit our website at ebpl.org.